Thank you for the invitation to present at this virtual meeting. My topic today is promoting healing in chronic wounds and international consensus on managing the gap. My name is Dr. David Keast. I'm talking to you from London, Ontario, Canada. I am a family physician who has spent most of the last 25 years in chronic wound management. I am the medical director of our chronic wound management clinic at the Parkwood Institute, a clinical adjunct professor of family medicine at the university, an associate scientist at the research center, and I'm also currently the co-director of the Canadian Lymphedema Framework. Thank you again for inviting me to present on this important topic. Our agenda for today is looking at managing the gap to promote healing in chronic wounds, looking at how we achieve this through the road to consensus at an international meeting. What consensus conclusions did we reach, and where are the conclusions, and where are we heading now? First of all, I think it's really important to look at the most important conclusion of the consensus meeting, and that important conclusion was that managing the gap is essential to promoting healing in chronic wounds. So what do we mean by the gap? Well, what we mean is that the gap is defined as the space between the wound bed and the dressing, also referred to as dead space. Now, this is not a new topic. The first concept was first published 20 years ago. But what there hasn't been is looking at how we might go about doing this. So why is this important? Well, it's really important to manage the gap because we know that if we do not manage the gap, it will negatively influence wound healing. We also know that if we do not adequately manage the gap, we may get leakage of exudate onto the surrounding tissue, leading to maceration of the tissues and delayed wound healing. Further to that, if we do not manage the gap, it allows for bacterial penetration and increases the risk of impairment of wound healing through bacterial burden. It increases the risk of infection and subsequent development of biofilms, so that it's really critical then that we actually manage this particular gap. So how did we go about to achieving this road to consensus? Well, first of all, I want to talk to you a little bit about the gap objectives that we set. And really the focus was how to manage the gap between the wound bed and the dressings. As I've mentioned, existing literature identifies exudate as a problem and deterioration of peri-wound skin as important, but we have little provided guidance on how to go about doing that. We know how to manage exudate, but not how to manage the gap. So what do we mean by consensus? Consensus really is developed through a process aimed at creating a common understanding. So it's a common understanding of an issue or a problem. And it uses the concepts of critical thinking in order to accomplish this. And the important part here is that when we combine the critical thinking of a group of people, the result is greater than the sum of the individual parts. In November 2019, Coloplast gathered experts from around the world to develop a consensus on guidelines on optimizing wound healing. There were 85 wound care specialists from around the world from 19 different countries, as shown from all parts of this world in the map on this slide. What was the pathway that we used to get to consensus? Well, obviously, it all starts with a very thorough literature review. And that literature review then was used to develop an initial generalized questionnaire with the assistance of an expert panel. That questionnaire was sent out to our participants, 85 of them, and received feedback from them. The results were then analyzed, and as we analyzed those, we focused the second survey down onto key areas and sent that back out to our 85 participants. The results came back, these were analyzed, themes were developed, and questions around those themes were developed. And as you see in the picture over here on the left-hand side, this is one of the stations where one of the questions is listed at the themes at the top and questions below, and participants were invited to discuss this amongst themselves and to post their thoughts in terms of these blue Post-it notes. All of these blue Post-it notes were collected, collated, put together, and fed back to the consensus panel the following day. So it was impressive how response rates were that we had with this particular survey. When you're doing surveys, you're really interested in data quality, and that really is about the quality and as well as the accuracy of that particular data. A cutoff of 40% participation was set for both surveys to determine data quality. Well, in the first survey, we had 82% participation, and in the second survey, we had a remarkable 72% participation, suggesting that the data quality is excellent. What about the people that responded from our group of 89 healthcare professionals? Well, 69% of these had specialized wound care credentials. 61% of these, as seen on the right-hand side, were nurses, 29% were physicians, dermatologists, and surgeons, and 10% were other healthcare professionals involved in wound care. So it was a highly expert group. 86% of this particular group had more than 10 years worth of experience in wound care, and remarkably, 45% of the participants had more than 20 years of wound care experience, as shown in the diagram below. All of this was guided by a global leading expert panel, and our expert panel is shown here in this picture. It was a very collegial, hardworking group that steered this whole process through the whole situation. Feedback from the participants was excellent. One participant from the United Kingdom said, "We were not told, we were asked." Another participant from Germany said, "I think it is very important to gather global experts in wound care and to reach international consensus on clinical conditions such as gap or dead space." And from South Africa, it was a great experience to be amongst other wound healing practitioners, sharing their experiences and knowledge while impacting knowledge in itself. All of this was steered through Coloplast and through the Bain Group. The Bain Group did an expert job at steering all of this consensus process. And in fact, in 2020, this group won a Platinum Facilitation Impact Award. So what did we reach as consensus? Well, first of all, what do we mean by consensus? We define consensus as when more than 80% of the participants agreed on the statements and outcome measures. Although 20% may not have necessarily agreed, they did not disagree to these recommendations. And key themes emerged that wound care treatment should primarily focus on a healing environment and optimizing that healing environment. And one of the key things here is managing the gap between the wound bed and the dressing, and that gap management is largely a matter of managing exudate. So consensus was reached through collaboration with this wound care specialist group, and the consensus reached on the importance of effective managing the gap between the wound bed and the wound dressing involved three key areas: managing exudate, creating an optimal healing environment, and decreasing wound healing times. These results were all published in Wounds International in September 2020. So here are a sample of some of the areas of consensus reached. The first area of consensus is what should we focus on in following when assessing the gap. So looking for the assessment parameters. Well, first of all, we need to look at the depth, undermining, tunneling, any fistulas, What are the underlying wound bed structures? What is the tissue topography and what is its quality? Is there granulation tissue? How much necrosis is present? We need to assess the level of exudate, and we need to assess both its quality and quantity. We need to look at the age of the wound. We know from previous literature that the older the wound, the more difficult it is to heal. We need to assess for levels of bacteria, whether this wound is infected, whether there's bioburden present, whether there's colonization, or whether there's spreading infection. We need to look at the wound edge, and we also need to look at the peri-wound skin, because we know that if the wound edge is not attached, wound healing will be delayed. We know that if the peri-wound skin is macerated, wound healing will also be delayed. And what is the wound etiology? What caused the wound in the first place? Unless we remediate the underlying cause, the wound will not heal. Participants also agreed on why managing the gap was important. And the key things that they agreed on was that we need to provide a moist wound healing environment. We need to decrease the risk of biofilm development. We need to keep exudate from leaking out onto the peri-wound skin. We need to decrease the risk of infection, and we need to remove pooling of exudate from the wound bed. These are the key things that were agreed. Participants also agreed on what we should look for success factors when managing the gap. How do we know that we've been successful? So has the exudate been effectively managed? Is the wound healing as expected? Have we managed wound bioburden appropriately, and is there any evidence of spreading infection? Have we decreased the pain for the patient? Have we decreased or completely eliminated undermining of the wound? And have we decreased the signs or absence of maceration in the peri-wound skin? All of these are important outcome measures that we should follow. Participants also agreed on the most important dressing features to promote wound healing in chronic wounds. First, we look for antimicrobial properties. We look for the property of vertical absorption of exudate to protect the surrounding peri-wound tissue. We need to look for patient comfort. Can the patient wear the dressing? Are they able to apply the dressing? These are key factors. Is the dressing conformable? Does it conform to the wound bed to eliminate that gap and to eliminate pooling? In today's wound care environment, we need to understand whether the dressing is in fact cost effective and it does what it says for the least cost. And does it promote a moist wound healing environment? So we have consensus that the wound should also be assessed on a regular basis. And furthermore, this group highly agreed that the wound should really be assessed at each dressing change. If you look at the graph down here at the bottom, you can see almost 100% either strongly agreed or agreed that assessment should occur at each dressing change, particularly looking for the risk of infection and increasing the protection of the wound. And in particular, we should use the triangle of wound assessment, looking at both the wound bed, looking at the wound edges, and looking at the peri-wound skin. So what were our conclusions and what are our next steps? So what we really need here is an evidence-based and experientially based, accessible guidance on how we go about managing the gap in the wound bed. We need a guidance document that will help stop routine practices. One of my colleagues always says, if you do what you've always done, you'll get what you've always got. We should stop being dressing changers and we should start being wound carers when we look at the whole patient and try to assess where we're going. And we need guidance in that particular area. So what are our next steps? Our next steps are actually to develop these guidelines and recommendations. And this is a process that is now underway. So we are continuing the collaborative effort with healthcare professionals from around the world to develop treatment guidelines. So this started out with the publication of 4 articles. The first was Managing the Gap, which was published in September of this past year. The second article in Wounds International was on exudate management and from the consensus group, and that was published also in September. We then looked at preventing and treating wound infections and biofilm, and this was published in December of this past year, and holistic approach to wound management is to come very shortly. But further, we need to move forward, developing the guidelines for managing the gap in chronic wounds and creating that healing environment. I'm pleased to say that over 2,000 participants worldwide are now involved in this consensus project to look at developing approach and guidance on how we go about managing the gap in chronic wounds. In closing, I want to remind you about the mission, vision, and values of Coloplast. Their mission is managing life easier for people with intimate healthcare needs. Our values: closeness to better understand, passion to make a difference, respect and responsibility to guide. And their vision is setting the global standard for listening and responding. I want to thank you for this opportunity to have presented this wonderful consensus process on managing the gap in chronic wounds.